of presenting here at your webinar. My name is Abdullah Al-Jaja, and Erin Alushai will be joining me in this webinar. So we'll be talking about sleep and Parkinson's disease, how sleep is like the microstructure of sleep, how is it affected in Parkinson's, and how medication affects these cycles. And also we'll be talking about methods of improving diagnosis that are related to sleep and Parkinson's disease as well. So I would like also to thank our sponsors, AbbVie, which is a pharmaceutical company that combines advanced science, expertise, and passion to solve serious health issues and have remarkable impact on people's lives. So before we go ahead and start, as they said before, I'm co-supervised by Dr. Penny Macdonald and Dr. Jessica Grahn. But in the Macdonald Lab, we have a lot of studies that look at different aspects of Parkinson's disease. For example, we have studies that look at sleep microstructure in relation to Parkinson's disease, and how medication affects the sleep cycles. We also look at gait difficulties, and in particular, we'll look at freezing of gait in Parkinson's. We're using virtual reality paradigms and medication manipulation to look at ways to reduce these gait difficulties. We also have one of the best driving simulators that looks at driving in Parkinson's and also ways to help them overcome some difficulties in driving. And as I said before, we also have auditory processing using EEG and functional magnetic resonance imaging, as well as cognitive behavioral tests and brain structure and connectivity. And we recently added alcoholism and obsessive compulsive disorders to our lab and venue to look at. So if you want to participate or you're interested to hear more about the study, you can always call us at these numbers or email us, and we'll get back to you as soon as we can. So now, to look at sleep and Parkinson's, and what is sleep? And I want to say that all of us enjoy sleep. Females, males, children, well, maybe not all children. So sleep is a complicated and dynamic process that ultimately affects how human being functions. And as you sleep, your brain will move through several different stages. Each of these stages will have different characteristics and may not be visible at the eye level, but that's why we use different techniques such as EEG, and in general we use polysomnography or PSG to record these sleep cycles. And so these are devices that record brain activity and help us discern which cycle we're at. So in general, what is sleep? Sleep is divided into two stages, non-REM and REM, and REM here stands for rapid eye movement, so non-rapid eye movement or rapid eye movement. And for the former, which is the non-REM, it occurs first and it's characterized by slow brain waves, and it also helps us transition from light to deep sleep. And as you can see here on the figure, we have stages 1 to 4 or 1, 2, 3, 4, and these are NREM sleep stages, and I'll talk about each cycle, each part in a second. And the other is REM or rapid eye movement, where we have fast brain waves and we have eye movements, and we also have dreaming in this cycle. So stage 1 and 2 are light to shallow sleep, and stages 3 and 4 are deep sleep, and it's a lot harder to wake up. So, and as you can see here, we have this progression from light to deep sleep, and I'll talk about each stage now. So stage 1 or NREM 1 typically involves the act of falling asleep. So you can feel extremely sleepy and you may have challenges keeping your eyes open for a minute. And also there's drifting in and out of sleep for some time. And at this stage, you can be awakened even by the slightest noise, and you'll feel as though you have not got any rest. And this stage is preparation for deep sleep. It is shallow sleep, but it helps us to prepare for deep sleep because brain waves slow down, the breathing and heart rate will also go down, and the muscles will relax, and body temperature will start to fall as well. So consciousness will start withdrawing from reality, and you have this sensation of falling. And this happens because muscles are still active and they may suddenly contract. So the other stage is stage 2. And in this stage, the eye movements will completely stop and brain waves become significantly slower. The body temperature will also decrease, muscle will relax even further, and heart rate will slow down. And the activity changes here between stage 1 and 2. So although there's no clear cut, but there's a change from stage 1 to stage 2. And stage 2 constitutes 50% of total sleep time. And it's easy to wake up during this stage, although it's a bit harder than stage 1. And the third stage is when sleep becomes deeper and deeper. And it's hard to wake up from this stage or from this sleep stage, and you can sleep through literally anything. And if you wake up during this stage, you'll feel disoriented and you want to sleep more. And infants sleep more during this stage, and that's why when you sleep well, you say, I slept like a baby. And the fourth stage is NREM 4, which is similar to stage 3, and it's hard to wake up, and it's the slowest brain waves. And currently stages 3 and 4 are combined and referred to as one stage, which is stage 3. So the other part of sleep, which is the REM sleep or the rapid eye movements, here we have the intense dreaming and the body is fully relaxed. And this is when we have sleepwalking, night terrors, or bedwetting episodes. So this is dreaming stage, and that is why the body should be fully relaxed. So in case the muscles were not, then we start acting out our dreams, which, as you can know, can bear some severe consequences. And it's important to note here is that Parkinson's disease patients have difficulty maintaining the sleep stage. And this is where problems happen with Parkinson's patients. So just a brief overview about Parkinson's. So Parkinson's disease is a neurodegenerative disorder that is characterized by the loss of dopamine-producing neurons in the brain, and the symptoms include bradykinesia, tremor, postural instability, and rigidity. However, these are the motor symptoms that Parkinson's patients suffer from. There are several non-motor symptoms such as cognitive disability or even sleep that are affected in Parkinson's disease. And today, I'm going to focus on the sleeping disorder associated with Parkinson's disease. So PD has been linked to different sleep disturbances, and sleep disturbances can affect up to 98% of Parkinson's patients, and that was a study done in 2012. Some of them is the REM sleep behavior disorder, or RBD, as we can see. And this can be used as a clinical indicator of motor symptoms or even disease progression. And Erin will be talking to you more about this shortly. And the other is excessive daytime sleepiness, which is sleeping during your waking hours. And it's a key determinant for quality of life for patients because it might lead to sleep attacks and insomnias, for example. And most importantly, sleep attacks might prevent you from performing everyday tasks, for example, driving or walking or doing your daily activities. In addition, there are other symptoms such as restless leg syndrome or non-REM parasomnias, where you start like vocalizing your dreams, or it's called nocturnal vocalization. So what is happening also in Parkinson's disease is that we have sleep fragmentation. And this is characterized by this burst of awakens or burst of awakening while you're asleep. So the previous graph that we saw that there's a transition from deep sleep, from shallow sleep to deep sleep, and then to REM sleep, which is where you dream, and then afterwards you go back, and each cycle takes around 90 to 100 minutes, and you pass through approximately 5 cycles a night. However, in Parkinson's disease, there are some disturbances and there are some brief awakening cycles. So you wake up, you're not able to go back to bed, you start waking up again and you go use the washroom. So you have a lot of difficulties during this stage, and that's why it's hard to maintain a full cycle, which makes it difficult to function properly. And that's why like you get awakened 2 to 5 times per night. But another piece of the puzzle is the effect of medication. And as you can know, levodopa is the main medication for Parkinson's disease patient. But what happens and what effects does levodopa carry on sleep? So in general, sleep impairments can be a direct result of aging, as results can say, but some sleep impairments can result from underlying pathology in the Parkinson's disease. However, there are other studies that also attribute the sleep abnormalities to dopaminergic therapies. But how does L-DOPA affect our sleep? If you do a quick scan in the literature, you will find a plethora of articles that talk about Parkinson's, sleep, and dopaminergic medication, and for sleep attacks, daytime sleepiness, and how modulation of L-DOPA, and hundreds or tens of papers that look at this. So we decided in our lab to look at this effect, or the effect of L-DOPA on daytime sleepiness. But we wanted to tease apart the medication effect, so that's why we ruled out any aging population or any Parkinson's disease patients. So we decided to recruit healthy younger controls between the ages of 20 and 35, and we tested them twice using PSG, which is polysomnography, as I said before, and it's recording brain activity and as well as heart rate, blood pressure, and all these variables. And we tested them twice, once on L-DOPA, which is the main medication, and once on placebo or cornstarch. And each session was a 90-minute session. And again, the session here was between 12 and 4 p.m. So we can have this where they have regular nap cycle, or where we can actually capture the napping structure here. So what we found here was that if you look at these two graphs, we have on the x-axis or the horizontal axis, we have the medication, L-DOPA or placebo, and on the y-axis, we have the time in millisecond, or the latency here to the stages of sleep. And we decided, and what we found difference in was the latency to non-REM stage 2 and non-REM stage 3. And what we found is that medication reduced the latency, meaning that we're getting into sleep or deep sleep faster on medication compared to placebo. And we found that participants had significantly reduced latency for both these stages. And also there was a trend towards an increase in total time spent in stage 2. And these effects appear to be sleep stage specific, as we observed no alteration in the amount of total sleep time, sleep efficiency, number of awakenings, or total time spent awake after sleep onset. And here, for the first time, we have demonstrated that levodopa is capable of producing specific alterations to the macroarchitecture of sleep within healthy controls and independent of aging and Parkinson's disease. So, in order to look more into this and dive deeper into our RBD, Aaron will talk to you about his study that looked at imaging in early stage Parkinson's and REM sleep behavior disorders in association with Parkinson's disease.
All right, thank you, Abdullah. So we are interested in sleep for reasons beyond just how it can impact Parkinson's disease patients, because there's an intimate link between sleep disorders and the development of Parkinson's disease. And I will be going through one study that we did using an iron imaging technique in order to try and link early stage Parkinson's disease with REM sleep behavior disorder, or RBD. So as Abdullah mentioned, rapid eye movement sleep, or REM sleep, is the stage when dreams normally occur. And this was discovered way back in 1953. And then in the 1970s, clinical reports surfaced that reported dream enacting behavior. So people were acting out their dreams. But it wasn't until 1986 that REM sleep behavior disorder, or RBD, was recognized as a clinical disorder. And 4 years later, it was classified formally as a parasomnia, or a sleep disorder. And even back then, RBD was found to be associated with neurological diseases like Parkinson's, but it wasn't until 20 years later that RBD kind of became a focus in neurodegeneration research, and it was no longer treated as just a sleep disorder, but rather a potential early indicator of neurological disease. So RBD is a sleep disorder in which patients act out their vivid dreams, and this results from a failure of normal muscular paralysis during REM sleep. So our bodies will normally try to paralyze themselves in order to inhibit any movement during REM sleep. So we don't, for example, start running when we dream that we're running. But in the case of RBD, a failure occurs and patients will actually act out their dreams. So RBD is characterized by vocalizations. So patients may begin talking as they would be dreaming of the words that they're saying during their sleep. They may experience minor movements, so these are called jerks, as well as complex motor behaviors. And almost always these actions are associated with the dream content. And there are many clinical implications of RBD that range from unnoticed sleep disruption to severe self-injurious behaviors and or injuries to bed partners. So the majority of movements as a result of RBD are minor in nature, and we refer to them as jerks. So we can see that here, where the fingers are slightly twitching, the wrist is moving slightly, or in other cases, we can see larger, more complex behaviors. So here, for example, we can see some grasping motions, but punching and kicking behaviors can also result in RBD. Now, our lab is interested in RBD because of its relationship with neurodegenerative diseases such as Parkinson's. And in one study, researchers in Spain followed a group of 44 patients for 18 years. So this is normally a very long time for longitudinal research. And they found that 90% of the RBD patients developed a neurological disease on average 10 years after their RBD diagnosis, or 15 years after the estimated onset of their RBD symptoms. And out of 44 RBD patients, 16 of them went on to develop Parkinson's disease, and this occurred on average 5 to 6 years after their diagnosis. Another 14 patients went on to develop dementia with Lewy bodies, or DLB, and this is a disease that shares similar symptoms with Parkinson's and is classified as a Parkinsonian syndrome. So it's like Parkinson's disease, but not necessarily labeled as Parkinson's disease. Another 5 patients went on to develop mild cognitive impairment, which is an early form of dementia. And lastly, 1 person developed multiple systems atrophy, or MSA, which is again another Parkinsonian syndrome. So clearly, the majority of RBD patients developed neurological diseases of a Parkinsonian nature. Now, to kind of briefly summarize Parkinson's, it is a disease that is caused by the loss of dopamine-producing neurons in the midbrain. Specifically, the substantia nigra pars compacta, or SNC for short, degenerates first, and this leads to the common motor symptoms of the disease. Then, in late stages, an area of the brain called the ventral tegmental area, or VTA, degenerates, and this leads to non-motor symptoms. Now, we know that the SNC is affected to a greater extent, as we can see over on the graph to the right, but we have yet to determine what causes the loss of these neurons and what could explain the difference between their vulnerability, so comparing the SNC to the VTA. But we think that RBD may actually be a key for understanding the cause of Parkinson's disease, because RBD is a substantial risk factor for development of neurodegenerative diseases with alpha-synuclein deposits. And the most common of these is Parkinson's disease. And as we saw in the earlier study, 50 to 70% of RBD patients develop one of these disorders within 10 years of their diagnosis. And so this makes RBD the strongest predictor of neurodegeneration that we currently have available to us. RBD can also exist for years or decades before Parkinson's disease motor symptoms appear, so it provides a large enough window to study the changes in the brain that are related and can potentially predict Parkinson's disease. In this particular study, they used a technique called dopamine transporter imaging, which we normally use in Parkinson's patients to provide a more formal diagnosis in some cases. But in this study, they performed the same technique in RBD patients to look at dopamine uptake in a part of the brain called the striatum, which is another main region that is impacted by Parkinson's disease and is directly connected to the SNC and VTA, which I mentioned earlier. And RBDs, so the study found that RBD patients that converted to Parkinson's disease showed greater abnormalities on DAT imaging. So looking at the top row, we can see an RBD patient that had more normal dopamine uptake. So the majority of the dopamine seems to be concentrated in the red and warmer color areas, whereas the patient on the bottom went on to develop Parkinson's disease after 3 years, and we can see a lot of purple spots starting to appear and less of a concentration or orange-white circle appearing in the area of the striatum. And they also kind of graphed this out. So the same study showed that the patients that had converted to Parkinson's disease, which we can see in blue on the figures, so they're the blue lines just below the lines in green, they had lower dopamine levels to start off with, and they had a faster decline compared to the RBD patients that did not convert to Parkinson's disease. And this was in all 4 subregions of the striatum. So not just one area, but all 4 of the anatomical regions of the striatum. And RBD patients also had lower dopamine uptake compared to healthy controls. So we know that DAT imaging can be used, but it has some downsides in that it is rather expensive and very intrusive, given that patients are being injected with a radioactive compound in order to kind of perform the imaging. So what we would like to do is potentially use another imaging technique, such as magnetic resonance imaging, or MRI, because it is non-invasive. So researchers in Italy conducted an MRI study that they had paired with previous work with DAT imaging, and they found that the anatomy of the substantia nigra was abnormal in about 60% of RBD patients, and nearly 90% of RBD patients if they showed abnormal results on their DAT imaging. So RBD appears to have less dopamine going to the striatum, and this is a result from the changes in the substantia nigra that resemble Parkinson's disease, which lends tremendous support for RBD being an early form of Parkinson's disease and highlights a need to find similarities between these 2 clinical groups. And the way that we do this is by looking for something called biomarkers that are similar in both patient groups. And biomarkers are measurable substances that are indicative of a disease state. So they kind of indicate the presence of a disease. And currently we have no validated and reliable Parkinson's disease biomarkers, but again, everyone is kind of putting their effort into proposing lots of different candidates for this, and we tend to focus more on imaging biomarkers. And biomarkers tend to come in one of 3 categories. So if we are looking at this diagram here, we have the disease stage plotted on the horizontal axis. So we go from preclinical to prodromal to the clinical stage of the disease. And we have worsening symptom severity as we go from top to bottom. So as you go down the vertical axis, symptoms get worse and worse. So someone who is aging normally would look like the line in green, whereas a patient who goes on to develop Parkinson's disease would look like the line in red. And a diagnostic biomarker, which we show in blue, would be able to distinguish Parkinson's patients from controls as soon as they enter the clinical phase of the disease. A progression biomarker, which we've shown in purple, would change with the advancement of Parkinson's disease so that we can distinguish early stages from late stages. And lastly, a preclinical biomarker is something that exists years before the appearance of these symptoms, but it allows us to, again, kind of predict who will go on to develop Parkinson's disease even before the appearance of motor symptoms. And we know that RBD can exist for years before any symptoms appear, so it provides a unique opportunity to study the changes in the brain that precede these symptoms. And the discovery of these preclinical biomarkers would allow for earlier diagnosis and provide potential therapeutic targets for neuroprotective treatment. And this would ultimately improve health outcomes for patients who are suffering from Parkinson's disease, because we could postpone or even halt the progression of the disease should we have these preclinical biomarkers in place and the capability to kind of predict who will develop Parkinson's. Now, studies have uncovered some potential biomarkers that they believe could be used to link Parkinson's patients with RBD patients, but our lab is mostly interested in the last two, which reflect differences in dopamine activity in the striatum as a result of changes to the substantia nigra. So we want to know if what substantia nigra features, especially those of the SNC, can link RBD and Parkinson's. And we used MRI to image iron in the brain, specifically in the substantia nigra pars compacta, or SNC, of early stage Parkinson's patients, as well as healthy controls, to see if we can use that in a diagnostic way. And fortunately for us at Robarts Research Institute here at Western, we have a 3T MRI scanner, which is much more common, as well as a rare 7T or 7 Tesla MRI scanner, which has a much larger magnet and can produce greater picture quality. So why do we care about imaging iron in the brain? Well, evidence suggests that iron overload could be a causing factor or contributing factor in Parkinson's disease. Iron can help oxidize dopamine to create this molecule called aminochrome, and this excessive buildup of iron and aminochrome can have neurotoxic effects. So they combine to kill neurons or brain cells in the substantia nigra. And the way that they do this is through the formation of alpha-synuclein oligomers, so buildup of this protein in the brain that leads to cell death, through dysfunction in protein and things called mitochondria in our cells, as well as by creating something called oxidative stress. So all four of these can contribute to cell death as a result of excessive iron buildup. So it is crucial that we image iron to locate where it is in excess and behaving badly. And the most common method that we use is something called R2 star relaxometry, which measures the relaxation rate of hydrogen atoms in our brain. And in the presence of iron, hydrogen atoms will relax faster and generate a larger R2 star value or brighter spots on R2 star images. So if we look at the arrows over on the right, they indicate the substantia nigra of a Parkinson's disease patient. And we can see that they are brighter than the control over on the left, which would indicate higher iron values in a Parkinson's patient. We also have this newer technique that is called quantitative susceptibility mapping, or QSM, that tries to directly image magnetic susceptibility or directly image this iron without necessarily looking at hydrogen atoms. And so in cells, when iron is present, it makes the tissue more magnetizable. And so it will appear brighter on these QSM images. And again, if we look at the white arrows over on the right, we can see that the substantia nigra bands of a Parkinson's patient are brighter than those of a healthy control. And so this would suggest that we can use this as a way to diagnose Parkinson's potentially. And in another study, they found that these QSM values were correlated with clinical measures like the disease duration, motor symptoms as experienced in the throughout your daily life, as well as the amount of dosage of levodopa that Parkinson's patients were taking. But R2 star was not correlated with this. So given all of this, we hypothesized that QSM might be a better imaging technique and can probably best detect the increased iron in the SNC of early stage Parkinson's patients and potentially in RBD patients. So we predict that there will be increases only in the SNC of Parkinson's patients with sparing of other areas such as the VTA and the SNR. We also believe that or predict that QSM will outperform R2 star in a diagnostic manner. So the way that we tested this was by scanning 17 Parkinson's patients and 21 elderly controls, once on our 3T scanner and once on our 7T scanner. And we didn't have any significant differences in our cohort, and all of our Parkinson's patients had the disease for less than 5 years and were receiving dopamine therapy at the time of the scan. So the way that we kind of look at these structures is by using this atlas to look at all of the areas that we were interested in. So the SNC is shown in blue, and this is just a 3D model of one patient, but we map out this model on every single person's brain. And we can see the yellow area is the other half of the substantia nigra called the SNR. And then lastly, those red kidney bean looking structures are the VTA, or the ventral tegmental area. And so what we do is we apply this 3D model onto someone's brain, and we cut out the areas that we are interested in, as you can see there, for both the QSM and the R2 star maps. And then we get a measure of the average iron content in their brain. So these are some of our results. We have the 3T data on the left and the 7T data on the right. And we can see that the average iron concentration as measured by the average susceptibility on the QSM map was significantly higher in Parkinson's disease patients compared to controls in the substantia nigra pars compacta. So this would make sense because this is the area that's first affected by the disease. So we would expect to see changes in this brain structure early on. When we used R2 star, however, we could only detect differences between patients and healthy controls at 7T. So it didn't work at 3T. This would suggest that R2 star is a less sensitive measure than QSM and perhaps is not as clinically relevant because we only have 1 or 2 7 Tesla scanners in Canada, but many more 3 Tesla scanners. So we would hope to find changes in 3 Tesla so we could have a greater transition to the clinic or translation to the clinic from our results. Moving on, here we are looking at the SNR, so the other half of the substantia nigra, and we see similar iron levels in this structure, but no differences between Parkinson's patients and controls. And this was the case for both field strengths using the QSM data, as well as the R2 star data. So we didn't find any differences. And this would highlight the importance of splitting up the substantia nigra to look at only the SNC for diagnostic and preclinical purposes. And then last but not least, we have the VTA, and this had the lowest iron levels of all three structures, and potentially could explain why the VTA is affected in late stages of Parkinson's disease rather than early stages. And we saw no differences again for the QSM data at 3T and 7T, as well as for the R2 star data. So for the next part of the study, we were interested in the ability of this iron measurement to serve as a diagnostic biomarker. So to do this, we ran something called an ROC curve analysis, where we plot the likelihood that someone is labeled with Parkinson's disease when they have the disorder against 1 minus the specificity, which is the likelihood of incorrectly labeling someone as a Parkinson's patient when they are in fact healthy. And so a perfect diagnostic biomarker would look like the red line over on the left, and it would have an area under the curve, or AUC, of 1.0, which represents 100% diagnostic accuracy. A biomarker that is just guessing would have a line that looks like the green line over on the right and have an area under the curve of 50%. So this is a 50% chance in terms of, if you think about a coin flip, just heads or tails, it's not doing a very good job. And then in between these two, we have an excellent biomarker, which is about 90% diagnostic accuracy, shown by the blue line in the middle. So this is our data for the 3T QSM of the SNC, so the area that's first affected in Parkinson's disease. And when we looked at the more affected hemisphere, we found that we got a diagnostic accuracy of about 87%, which is approaching excellent. And then for our 7T data, we had a diagnostic accuracy of about 81%, which is again good to excellent. The main reason for the differences between the two is the fact that the 7 Tesla scanner is a bit more sensitive to motion. So we had to remove some patients as a result of excessive movement in the scanner, but there wasn't any major differences between the two. So both the 3T and the 7T QSM data fall in the good to excellent range for diagnostic biomarkers. And then looking at the 7T R2 star data, we had a diagnostic accuracy of about 73%, which falls just short of the 80% cutoff, which is considered a good biomarker. So this would suggest that QSM is actually a better diagnostic method than R2 star in early stage Parkinson's disease. And so to kind of summarize the study, QSM found elevated SNC iron content in early stage Parkinson's patients at 3T and 7T, so using both of our scanners. But R2 star could only detect this elevated iron at 7T. And we didn't see any differences between the groups in the other areas we looked at, so the VTA and the SNR, in terms of their iron content. And QSM also sorted Parkinson's disease patients better from controls from controls better than R2 star imaging, which would suggest that QSM is a better diagnostic biomarker and could be clinically applicable for use in early stage Parkinson's. And we are currently performing a study to repeat the methods that we used in our early stage Parkinson's patients in a group of RBD patients to look for similar changes in iron to hopefully find preclinical biomarkers of Parkinson's disease. And we've collected data from about a dozen RBD patients so far. The reason that we're only at about a dozen is because RBD is a much rarer disorder. About 1% of the population seems to be affected, and we're only interested in patients who have RBD exclusively without any other diseases or conditions of psychiatric or neurological origin. And we perform identical scans as what we did with the early stage Parkinson's patients, and we're using iron imaging techniques as well as a couple of other techniques, one of which is called diffusion tensor imaging, to look at the connections between brain areas. So we know that the SNC connections to the striatum are usually damaged in Parkinson's, and we're hoping to kind of find the same results in RBD patients. And we're also performing functional magnetic resonance imaging, or fMRI, and this allows us to look at brain activity during rest or during several tasks that we have developed in order to kind of measure dopamine deficiencies in RBD patients. And with that, I would like to acknowledge our supervisors, or I guess mostly my supervisors. Dr. Jessica Gran should also be in this list. My fellow lab members, especially Abdullah, for coming out to present with me today. The MRI technicians that we work with, as well as our sources of funding and all of the team here at Western University. And with that, we are happy to take any questions that you may have. And again, if you are interested in participating, please feel free to either call that number there or email us, and we will do our best to get back to you in a timely manner. Thank you.